Hello everybody and welcome to a new case. This is an elderly patient who presented with left-sided weakness. The abnormality is obviously seen here as a large area of intraparenchymal hemorrhage exerting mass effect with extension into the ventricular system. We've discussed before various causes of intracranial hemorrhage and intraparenchymal hemorrhage in particular, with hypertensive and traumatic causes being very common. Now, the teaching point of this case is not here, it's in the subsequent MRI, so let's go to that. Now, I'll give you a chance to look at the MRI performed on the same day. This sequence of the MRI is called a gradient sequence, on which calcium or hemorrhage typically shows this kind of dark artifact, this susceptibility artifact. We know that this area represents the acute hemorrhagic focus that we saw on the CT scan. We could see also the intraventricular hemorrhage showing a CSF blood level. However, what's extremely important in this case is to notice the other finding, which is represented as these dark multifocal areas that are scattered throughout the brain in the supratentorial system and the infratentorial components as well, such as the ones you see here. The most important observation when it comes to these small, tiny areas of low signal intensity on such sequence is to notice that they are peripheral in location. So they are cortical and subcortical. The other observation is that we did not see a corresponding abnormality on the CT scan. So if this were to be calcium, you'd expect to see these as calcified foci on the CT scan, which was not the case. So you know that these are areas of tiny chronic hemosiderin from hemorrhagic foci that are old and small to the extent that you could not see them on a CT scan, but they are exaggerated on such acquisition. Now, we confirmed that these foci are chronic areas of hemosiderin deposition from hemorrhage. Whenever you see those and you're thinking about hemorrhage, you have a few possibilities, but the two practical ones would be either due to hypertension or due to amyloid deposition. When it comes to differentiating such deposits, in the case of hypertension versus that of amyloid, if it's the more common hypertensive abnormality, you'd expect to see these dark spots within the center of the brain more deeply, typically within the basal ganglia or the brain parenchyma surrounding that, which makes lots of sense because these are very common areas when it comes to hypertensive changes and hemorrhage and others. If this were to be amyloid, such as the case that we're looking at here, the distribution of the abnormality is typically more cortical and subcortical in a peripheral nature. So to summarize, non-traumatic hemorrhage in an elderly patient is very commonly hypertensive, but could also be due to amyloid. Tiny hypointense susceptibility artifact foci may represent areas of chronic hemorrhage from hypertension or from amyloid. To differentiate between both, if it's more central in location, it's typically hypertensive. It's more peripheral in location, it's amyloid. Thank you for watching this quick case, and we'll see you with more cases later.